Hi there, my name's Dominic Hooley. I've been a dentist for 27 years, placing implants for 15 years now. I concentrate primarily in the aesthetic zone, and a lot of my work is now placing immediate implants. What I'd like to discuss today is a brief overview of immediate implants. They're a real cornerstone of my own dental practice. For me, it really simplifies, in one way, the patient experience. Fewer surgeries, a more predictable outcome in my hands, and in many cases it's allowing the patient to have less morbidity and achieve a really aesthetically pleasing result in a fewer number of visits. Immediate implants is a massive topic, and within this short video it's going to be a brief overview. What I'm going to try and discuss with you is my criteria for when I place immediately, and some interesting techniques that I'm using to help make my outcomes as predictable as possible. Case 1 is a lovely gentleman who had a failed upper left central incisor. This tooth had a split in the root, and secondly, unfortunately, had a cyst that was communicating with his incisive foramen. This is a complicated case. However, I felt that it was predictable for me to be able to do an immediate placement here using a novel implant called the inverter implant, and using ethos to both provide me with a way of augmenting the jump gap, but secondly, to improve the gingival form afterwards. I felt it was appropriate to do an immediate implant placement. Now, why did I think that? 1, patient was fully consented and very keen to have an immediate implant placement and loading. He's the kind of guy that I knew I could trust to follow my advice. Secondly, thick biotype, nice solid gingiva, and an intact socket. And thirdly, a lip line that meant that, say we did have unpredictability and a little bit of gingival recession, it wasn't going to be a deal breaker. We see the implant being placed. Now, you may be looking at this implant and saying, wow, that's unusual. This is a southern inverter implant. This implant has 3 distinct zones to it. It has an apical portion that achieves really high primary stability. It's got a central portion, which is in this case 4.5 millimeters wide. And then coronally, it's got a narrow coronal chimney with a much less aggressive thread on it, but at the same time, it's got enough room for that endosteal bone to form around the implant. Now, endosteal bone is bone containing marrow, and marrow contains blood vessels. And what I want to do is I want the bone around my implant to be full of blood vessels to really predictably keep that gingiva where I've placed it. Here we can see the implant in its correct 3D position. If you look very carefully here, you can see that there's a little dot on the shoulder of the implant. This shows that rotationally I've got the coaxis of the implant in the correct direction towards the palate. This implant has a 12-degree angle correction actually internally within the implant. And that's amazing because it allows me to place the implant right smack down the middle of the ridge, but at the same time have that screw access channel coming out on the palatal. Look carefully at this slide. You can see we've got an adequate jump gap that's circumferential around the implant, and the implant is deep enough to ensure that we've got enough soft tissue there to allow me to augment it predictably. And here we see I've placed the healing abutment on top of the implant, and this is important to remember before I then start to use my ethos into that jump gap. You can see the jump gap there, it's mainly towards the labial surface of the implant, but actually with this implant, there is a circumferential aspect of it as well. And what I try to do with my ethos here is also repair that cystic space that's connecting with the incisive foramen on this case. A medium mix, it's neither too wet nor too dry. I'm really keen that the ethos is in the top 2/3 of that initial jump gap. I'm not overly bothered whether I'm getting right up to the apex, because the body does very well at replacing that apical area with its own bone anyway. But where I really want my ethos is in the mid-third and in the coronal parts of that socket. And I want that for 2 reasons. I want it to predictably keep that ridge form in the long term, but secondly, I want to enhance my gingiva and really get good keratinized gingiva where we've got that connection between the crown and the implant. My ethos has now reached its setting phase. Ethos takes 3 to 5 minutes to set, and I use a sterile gauze pack against the ethos to allow that setting phase to happen. Take your time here. Don't be rushing it. Let your ethos set. And I've taken the healing abutment off. Look carefully here and see that we've got that beautiful set ethos, and you can see right down the implant. The ethos here is going to provide me with that very predictable enhancement of my soft tissues, and also the replacement of that jump gap with endosteal bone over a period of time. So again, we've got that combination of the narrow chimney portion of the implant, ethos in the jump gap, and the correct patient selection to ensure that we've got a predictable outcome. Here we can see that I've used a lab-made provisional crown on a peak abutment. The peak abutment has been attached to the implant and then the crown tried in over the top. And what I want to do here is achieve something that's going to be aesthetically pleasing for the patient during those first months, but at the same time be out of his occlusion during his centric function and also during his excursions, so that the patient isn't going to be loading this either during parafunction or during chewing. Here we see a CT scan on the day of placement. The cross-sectional view shows us the implant right down the middle of the ridge, and it shows us the ethos into the original socket of the tooth. More concerned about the middle and coronal portions of that socket than I am about the apical third. And the reason for that is the human body is very good at replacing that apical third. What we really want to avoid here is poor degranulation of the socket. So I must emphasise that you must degranulate your socket as well as you can. I tend to use my ethos burrs for that, as well as a sharp curette. And here we see now we're at the restorative phase. This is approximately 4 months after implant placement, complete preservation of that ridge form, an amazing emergence from that implant, and a beautiful gum collar ready to do the impression for his final crown. And here we can see the final crown's being fitted now. We can see that we've really tried to get a good colour match here. If anything, if I'm hypercritical, it's perhaps a shade too deep. But we've tried our very best here to get a good colour match with his other central incisor. Exceptionally complicated to do. So many things going on with his own teeth here. The texture of his teeth, primary and secondary colorisations of his teeth, and a complex incisal edge form on his tooth as well. And here we can see during his normal smile here, seamless. And what we've achieved here is a combination of 3 things. Exceptional keratinized gingiva. We've got an implant that's within the middle of the ridge with plenty of endosteal marrow-containing bone. And thirdly, we know that our ethos graft has been converted to host bone. And host bone gives us predictability for a long-term stable outcome, with preservation of his papillae, both between his central incisors and also between the left central incisor and his lateral incisor. And now we're looking at another case. This is an interesting case where we've got 2 failed central incisors. We've gone straight to a shot where we've taken the crowns off, showing the 2 fractured roots that are in place. This gentleman's in his early 50s, and what we're doing here is we're going to place 2 immediate implants for both central incisors, and we're going to immediately load both of them. So why have I done this? I've done this because in this case, again, we've got a thick biotype. We've got a patient who's going to follow my instructions after these implants and these crowns have been placed. And thirdly, is the type of patient who's concerned about multiple surgeries, but at the same time he's fully consented and he understands that there is an inherent unpredictability from going with this treatment modality. What's really important here is it shows that I've followed certain guidelines on the carriers, a vertical line on the carrier to show me the correct angulation, rotational angulation of the implants, and secondly, a horizontal line showing me the correct depth of the implants. You may well wonder, well, how's he placed these so accurately in this position? And I think that's experience here and exceptionally good visualisation. You must be very clear that you can see down your socket and that your initial osteotomy here is placed on the palatal wall of the socket, and you're careful with every single time that you upsize your drill that you are following your exact locational accuracy to ensure that your implant is in its correct location. And here we now see the implants are in position. I've placed my ethos, and this shot actually shows the set ethos after the healing abutments have been removed. It could be a little bit tidier. I think when I took this photograph, I'd not wiped some of the ethos away from the labial mucosa, but it's showing a real world case here. And what we're doing here is we're showing the circumferential jump gap around the implants has been augmented with ethos quite effectively here on two teeth next to each other. The ethos is going to allow me predictability with regard to gingival infill and preservation of that ridge form in the longer term. What really interests me here is you can see above the crown, between the cervical margin of the crown and the gingiva, there's a space. If you look carefully, you can see ethos there. Now you may be thinking, oh, he's left ethos exposed. And I have, and I've done that on purpose. I've done that because ethos is a bacteriostatic material, and I'm not concerned about getting post-operative infection, despite it being in obviously the bacterial contaminated oral cavity. Secondly, I find with ethos we get epithelial ingrowth across that ethos very quickly. So we're getting cell transfer from the margins across the ethos within days. So we're going to see on the next shot, 1 week after placement, you can see how that space is almost closed already. Now this is an advanced technique. This is something that you must stage yourself to get to this level where you're comfortable and confident that you can leave some ethos exposed. But in my hands, I find that I'm able to achieve very, very predictable gingival ingrowth with maintenance of the ethos within that to allow me to contain the ethos and have predictable ridge form in the longer term. And this shot showing me the absolute meticulous way that we've achieved an ideal emergence on these provisional crowns. We must achieve a convex contour between the peak abutment and the crown. It's really important not to have concave margins where you've got areas where you're going to lose your graft. You want your emergence profile of your crowns to be really helping with that gingival preservation. And it's so important that you polish them very, very carefully as well, so that you haven't got a plaque retention factor there. These crowns are going to be in place for a minimum of 3 to 4 months, and they could be in place for 9 or 10 months. So we want them to be really, really well polished to allow the optimum outcome with regard to the gingival emergence, preservation of the ridge form, and maintenance of that host bone. Well, this case is a case very close to my heart. This is my own son, Gabriel. Gabriel is a student in Liverpool, and what this case shows is a younger person, so somebody in their early 20s, who was assaulted, and unfortunately his left central incisor was assaulted in such a way he was punched, and it fractured off at gingival level. Now, for a year, I decided he was a little bit young for an implant, and so what I did was I root treated the tooth and cemented the crown back on, using his own tooth. Now, this photograph here shows a year later when the crown had actually snapped off again and had to be re-cemented by a local dentist in Liverpool. And we can see that it's an aesthetic compromise. And Gabriel was a little bit embarrassed about this. And from my point of view, it became really apparent we had to think about doing something more predictable and long-term for Gabriel. Now, looking at this cross-sectional CT scan image, what this shows us is that the root filling has allowed me to effectively preserve the root. We haven't got a large area or what we call a periapical radiolucency under that root. We've actually got an intact labial plate, so the bone is intact there. Wow, so lucky there. What you can see though is on the palatal side, there is a little bit of bone loss there, and that's associated with the fishtail fracture, where it's more apical on the root, on the palate side compared to on the buccal. And this is very common when you do get fractured central incisors, that the fracture goes from perhaps a superficial location on the labial side, but becomes a lot more apical on the palatal. This was one of the decisions that made me feel I had to go ahead with an implant for Gabriel. And I felt he was old enough now for us to do that in a predictable way for him. What I did was I placed an inverter implant, immediate placement, took his tooth out, placed the implant into the correct 3D location. This shot here, this photograph here shows the ethos has been placed. And here it shows that I've placed a peak abutment ready to pick up a provisional crown. Now, I think it could have been because I was a little bit nervous here treating my own son, but I traumatised his gum a little bit when I took his tooth out. And I think when you see the provisional crown fitted here, you'll see that there is actually a space between the provisional crown apical portion and the gingiva. And you can see that quite clearly there. Particularly just distal to the zenith of the crown, you can see that there's some trauma there. And if you look carefully at this slide, you'll be able to see the ethos peeking through there. Now you may be thinking, wow, you know, he's left ethos exposed again. I have. And the reason I've done that is because I know what's going to happen. And that gingiva is going to cross that ethos very quickly, very predictably. And here we see the day of placement, we've took another sectional CT scan. And we can see the inverter implant down the centre of the ridge. And really clearly on this, you can see that I've got a very, very nice socket full of ethos. Not so much worried about the apical third, and I've mentioned that earlier in this presentation. But the middle third and the coronal third have got a nice, neither too tight, it's not super tightly packed, nor too loose, well-placed ethos graft. So this is what you need to be aware of when you do this treatment, when you're placing ethos into this socket. Place apically, but don't be as worried about that as about the mid-third and the coronal third. It's so important that you get your mid-third and your coronal third of your socket packed with ethos, but not too tight. Don't pack it super tight, but at the same time, don't have a really runny mix. Make sure it's just right, and that you've packed that middle third and the coronal third. And that's what we want, so that the host bone can come there and actually preserve that ridge form for you. What this is showing me is that on the day of a fit of his final crown, so this is about 11 months after placement, and I'm very lucky, I've got a lab upstairs, and we're able to do one of these lab try-ins where I'm actually trying the substructure of the crown on first. And look at that beautiful emergence that we've got there. Look at his gingiva. Look at the way the papillae, both distally and mesially, has been preserved. And that's testament to ethos, and it's testament to the correct position of the right implant. And when you're doing this type of technique, be aware, it's so important that everything is just so. Your implant is in the right place, vertically, labially, mesiodistally. Secondly, that you've used the correct material for your jump gap, guided bone regeneration. And thirdly, that your temporary crown, your provisional crown, has the correct emergence to support that gingival outline and form. And now we see the crown. The lab upstairs have now cemented the crown to the abutment, and this crown is made out of a zirconia material, and it's been characterised in the lab. And it just shows you that beautiful emergence that I've achieved, which allows us to again get the right degree of compression on the soft tissues, but at the same time, it's allowing the emergence to help preserve the bone around the collar of the implant. And if you look very carefully above the left tooth there, the left front tooth, you'll see that we've got a little bit of gingival blanching there. And that was placed about 2 minutes before this photograph was taken. And what I'm looking at when I'm placing this crown, I'm looking at that little bit of blanching where the blood supply to that gingiva is slightly reduced because there's a little bit of squeezing going on there. Can you see the distal papillae? It's a little bit white. And that's normal, but what's very important here is that that blanching starts to go away over the minutes afterwards. If we still had blanching like that after 20 minutes, that crown would be coming off and being adjusted. Because longer term blanching such as that can lead to a deterioration or unpredictability of the gingival outline, and you could end up with recession and loss of your papillae. So here we see a shot about 10 minutes after placement, and this is Gabriel lifting his lip up for me. I'm so pleased with this result. I mean, you know, what more could I ask for? I think it's a really great outcome here. Looking at both papillae, looking at the central papillae, the position of that frenum under his upper lip, looking at that distal papilla, one of the hardest things to preserve when you place an implant in the central incisor place. Look how it's there, and that's nearly a year after this implant was placed. Look at the symmetry between the two sides. And yes, we had a very slight cant on the centrals, but that was because of his own upper right central, and I'm afraid that was unavoidable. But to the casual observer, you're not going to notice that. And here we can see him doing a smile now, and we can see where his lip position is. You know, and I couldn't ask for better here. I think you can't tell which the implant is here. Maybe I'm wishful thinking. But what I notice on this shot is his distal papilla. It's perfectly symmetrical with the one on the right, and his mesial papilla position is where it was, even better than it was before he had this tooth removed. Again, it's a combination of three things: proper patient selection for an immediate implant. Second, the correct implant. So an implant that allows endosteal bone in the coronal aspect of the implant. An implant that allows you to angle correct so that you can place your implant down the middle of the ridge and at the same time have the screw access channel coming out on the palatal. And thirdly, using an alloplast ethos, which gives me predictable host bone over a period of months after the implant has been placed. I'm not relying on ethos to be a scaffold for years and years and years. I want my patients to have their own host bone there. And that's what I'm getting with ethos. This is a CT scan, sectional scan, 11 months after initial implant placement. Final crown's been placed. It's showing complete preservation of that ridge, apically and coronally. The ethos has been replaced by host bone. And just look at that palatal bone. Look at how the ethos in that circumferential jump gap has also allowed host bone to form on the palate side of this implant. I couldn't ask for better.